Good morning, everybody, or afternoon, depending on where you are. Today is February 10th, 11 o'clock Eastern or Central Time. We are going to go ahead and get started. This is the infectious disease echo. And just a second, let me share my screen. And if you want to go over the disclosures.
All right. Hello, good morning or good afternoon, everyone. I'm going to quickly, before we get started, just go over the disclosures. So this activity is jointly provided by United South and Eastern Tribes and Cardia Services. Sorry, I do have to just read this. So Cardia Services is approved as a provider of nursing continuing professional development by Montana Nurses Association, an accredited approver with distinction by the Nurses Credentialing Centers Commission on Accreditation. This activity has been planned and implemented in accordance with accreditation requirements and policies of the California Medical Association through the joint providership of Cardia and USET. Cardia is accredited by the CMA to provide continuing medical education for physicians. Cardia designates this live web-based training for a maximum of 1 AMA PRA Category 1 credit on January or on February 10th, 2023 today. Physicians should claim credit with the extent of their participation in the activity. We have Dr. Mara. He has received an honorarium from the AbbVie Pharmaceuticals for a presentation. He is also a principal investigator for clinical trials for Gilead Sciences, Pfizer, AbbVie Pharmaceuticals, and a principal investigator for a focus grant for Gilead Sciences. All relevant financial relationships have been mitigated. Emily Field, a planner, has a relevant financial relationship with healthwarehouse.com and Pfizer. All relevant financial relationships have been mitigated. And upon successful completion of this activity, 1 contact hour will be awarded. Successful completion of this continuing education activities includes attending this entire webinar, completing the online evaluation, which I will drop in the chat in just a second, and then submitting an online CE request. And your certificate will be sent via email. If you have any questions about the CE, go ahead and contact Kat McLaughlin. And I did just post that in the chat for you all, and I'll go ahead and post it a few more times throughout the webinar.
Great, thank you. If you would not mind putting your name and where you're from and what organization you're working with and what tribal nation you're affiliated with, that would help us out with attendance. And Gabby, did you want to say anything?
Yeah, I just didn't get a chance last time on the previous infectious disease echo. So thank you all for joining us today. You may have received any emails from me. I am the infectious disease program manager. My name is Gabby Niski. And I just wanted to point out as well of other things that we have going on in infectious disease in regards to the universal screening program that some of you may have gotten an email from me. I just wanted to point out that we are still doing this program on top of this infectious disease echo. And if you are interested, we are looking for medical providers to sit on key informant interviews. And if you all are interested and you would like to get more information, if you just would provide your email in the chat box, I will be more than happy to get in contact with you and get you on the schedule. Thank you.
Thank you, Gabby. And we can go ahead and get started with the first presentation of the EPI updates for COVID and influenza.
All right, let me just share my screen here. All right, perfect. You guys can see that all okay? Okay, perfect. So I'm Anna Garrett. I am a staff epidemiologist with USET. So we're just quickly going to run through some COVID and flu updates for the region. So first we'll start with COVID-19. We are using our same data sources that we have been using. I am just a little bit closer on getting this HHS Protect access back up and running. So I am hoping, fingers crossed, next month we'll have the updated data for that. And that is just this one here. All the other data sources have been updated accordingly and are the same as before. So this was kind of the top of the header report from last month, just showing the difference between this month. So most of the variants are the same. We are seeing this XBB.1.5 and then BQ.1.1 as kind of the main two that are circulating right now. We have had a decrease in the USET purchase and referred care delivery areas from 211 to 187. And we are seeing a decrease among all the USET states as well, from about 1,000 to 800 and about 67. We did have a slight increase in the total number of positive COVID-19 test results in the IHS Nashville area this past month out of 108, and that is about a 12.7% positivity rate. So just to quickly touch on the variants, since I know some of them have been in the news, so they are predicting that XBB.1.5 is going to go ahead and increase, and that's this kind of darker purple color here. It is already about 60 to 70% of the circulating variants, and we are just seeing that kind of slight decrease in the BQ.1.1, as we have been seeing for a little bit of time now as XBB takes over. Just by the HHS regions, so we're seeing a lot of the kind of USET regions here, being that majority of that dark purple color, which is the XBB. And then over here, kind of in the western area, we are still seeing BQ.1.1 kind of still holding on to some of its prominence over there. So the COVID-19 community levels, so these on the right here are just the same, the low, medium, and high, as we have been kind of defining them, just what you should be doing. So these were the levels in the USET states of last month, and then here we are this month. So you can see we have a lot more of those counties turning green into that low level and shifting as well to that medium, and then much less of those are in the high level. So that is good news. Just a whole kind of picture of the United States. This is from last month. This is from this month. So just seeing that kind of general trend of kind of those lower community levels. So the national wastewater surveillance, this was the one on the report for last month. We've been seeing most, pretty much all of the states are at these very high levels of COVID being detected in the water. So almost 100% of samples having COVID detected. And then this month, we are seeing just some of these states decreasing just a little bit. There are some states that did not report any, but we are kind of coming down off that trend of having all states being at 100% of wastewaters with COVID. For COVID-19 hospital admissions, this was from last month, and this is this month over here on the right. So we are seeing just the general decreasing trends. So the USET PERTA, USET states, and then United States as a whole, we're seeing all of those numbers decreasing. COVID-19 vaccination data. So we're seeing just some slight increases from last month of the reporting facilities in the IHS Nashville area, the United States, and then IHS as a whole. So just some slight increases there of the population fully vaccinated. Just some slight increases in the people partially vaccinated, fully vaccinated, and then additional doses. For the percentage of the population fully vaccinated, for facilities in the IHS Nashville area, we're still hovering around that 55.3%. And then depending what state you are in, if you're in the USET states, you can see kind of your percentages here. We are seeing Connecticut, Maine, Massachusetts, New York, and Rhode Island kind of leading the way there. For the percentage of population fully vaccinated that have received another COVID-19 booster dose, So these are kind of much lower percentages. This is that new booster dose, that bivalent one that was kind of recently brought out. So we are seeing about 21 or so % of these facilities in the IHS Nashville area. And then the other states are kind of following those general trends, but there is some room for increasing the booster doses for this as well. But still trending upwards, so that's good. These are the data sources if you're interested in going to any of them yourself. I did just want to bring to your attention, in case you were unaware, it looks like the COVID-19 national emergency and public health emergency is set to expire on May 11th of this year. It doesn't seem like the White House has any plans of extending it farther than that at this point. So I did just want to bring that to your attention, and that was announced at the end of January. So now on to the influenza update. These are the data sources for our flu report. So I compile some different kind of sources. I mainly rely on the CDC weekly influenza report, looking at the percentage of positive influenza tests, the influenza-like illnesses, hospital admissions, the ILI activity by state level, the percentage of outpatient visits for respiratory illness, and then I also use Indian Health Service weekly influenza report as well to get the percentage of ILI visits for the national and Nashville area, as well as the seasonal vaccination rates for LHS. So some general information, I believe we went over this last month, but it's just a bi-weekly report. Just wanting to get out general trends in influenza, just kind of for your awareness. The data is reported by MMWR Week, which is the Morbidity and Mortality Weekly Report. That goes by the number of the weeks. So, for example, the first week in January was week number 1, and it goes from there. I do just want to note that influenza-like illness is not a laboratory confirmed influenza case. It is just a respiratory illness that includes a fever plus a cough or sore throat. So it may encompass things more than just influenza. All right, so kind of an overview. This was the most recent one that we had sent back this Wednesday. This covers the morbidity and mortality week number 4. So that is that last week in January. So we are seeing general decreasing trends. The percentage of influenza positive tests reported from or to CDC has decreased about a percentage from week 3 to week 4, and we're at about 2.1% now. The weighted percentage of visits for ILI has remained at 2.6 from week 3 to week 4, so no change there. Number of new influenza hospital admissions is decreasing by a little over 1,000 from week 3 to week 4, and we're averaging about 2,600. The percentage of ILI visits for IHS nationally is at about 1.2%, which is decreasing about 0.5% from the week prior. And then for the Nashville area IHS, it's sitting at about 2.3%. Which is a little bit higher than national levels, and it is just slightly decreasing from the week before. So up here on the top, we see this nice map of the United States. So this is for the ILI activity level by state. So just reiterating again, this isn't just specific to flu, it's just flu-like kind of respiratory illness. We can see most of the states here in this green and yellow category, indicating lower levels of influenza-like activity in their states. We do just have a few kind of right here that are getting up there, but the highest level we do have is 11, which has decreased a lot from kind of the maps we've seen previous that have had quite a few of the states at level 13, which is the highest level. Down here on the bottom kind of right area, we do have the percentage of outpatient visits for respiratory illness. So we are the kind of black line with the red triangles. That is the 2022 to 2023 season that we're in right now. So you can see kind of the beginning of the season, we have this really, really sharp increase, reaching kind of very high percentage of visits for influenza-like illness. And now we're here kind of dropping off back to this 2022-2023 baseline, which is this kind of checkered black line right straight across here. And you can compare it to other seasons as well in the past by the different colors. And we're seeing that we are kind of at substantially lower flu rates right now at this time of the year. For the 2021 or 2020 to 2021, and then the 2021 to 2022, which is this pink and orange line. That was during kind of COVID time, so a lot of people were wearing masks. They were, staying far apart. So that's likely why this is so much lower. But we are doing relatively well. It's a good news that we're coming down off this. So the vaccination rates over here on the left, comparing all the different IHS regions. Nationally, we're at about 28.2%. Nashville is doing as a higher percentage at 31.3%. There is still some room for improvement here, but we are doing really well in the Nashville region. Over here, by age group in the Nashville region, we have about 24.5% of the children with their flu vaccine this year, 33.9% of adults, and then 57% of those 65 and older. So that's good. And we have been seeing increases in these numbers from week to week as well. So that's good. And then finally, we have the number of new hospital admissions by HHS Protect region. So we have the regions in which states they are over here on the right. We can see nationally again, we're kind of coming down off that large peak. And then all the other regions are kind of at about the same level here, but decreasing as well from that. So that is the end of the COVID and flu updates. If you do have any questions, please just feel free to reach out to our USET EPI email, or if you want to talk to me directly, you can go ahead and email me as well.
So I have two questions, Brian, if I may.
Yes.
That was a great presentation, Anna. Thank you. So two questions on the wastewater data. So when the wastewater peaks, what is the timeline for prediction of outbreaks in the population?
Yes, so in this kind of context, we're using wastewater. It is kind of the earliest warning system that we have in relation to like hospital admission or testing or anything like that, since you don't have to actually do anything. you're just shedding it. So the metrics we use, it's basically the percentage of those samples that are positive for COVID-19. Since I aggregate it together for kind of all the different counties that a tribal nation may, have overlap in, and the sewer sheds are not, defined by the county lines or anything like that. That's why I'm using that metric, because it's a little bit easier to aggregate. So kind of as a whole, I'm just kind of using it just to see general trends. In this kind of context, it would be really hard to use it as an early warning system unless we were really able to get down to that, specific sewer shed level and see what exactly, that facility was doing, but just kind of as general trends.
Okay. Thank you. And my other question was, and if you don't know on the top of your head, it's fine, but what percentage of confirmed influenza or ILIs, for that matter, does the CDC use to say, okay, we have an epidemic, the epidemic has started or the epidemic has ended? Is there a cutoff that they use?
Yes, I believe there is a number and a calculation. I do not know it off the top of my head. I believe it is the baseline for kind of on that, but on that chart. So on this chart here, they have done all of their calculations basically to say that this is the baseline, this dotted line for 2022 to 2023. So we are kind of reaching that baseline, and every year it does change just based on whatever kind of calculations they're doing. So we are kind of dipping off here, hopefully, is what it looks like.
It'd be like 2.5%
It looks like that approximately, yeah.
realized. Okay, thank you.
Any other questions for Anna at this time?
Hi, this is Dean Seneca. And a great presentation. I was looking at some of those maps and I just wanted to know, when you're comparing data in the USET area, is it the states in which the tribes reside that make up USET, or is it the tribes within the USET area that you're comparing to other states or or the rest of the nation? Because some of those maps included, I think there were like all the Chisda counties, but it was like the whole state. So I just wanted to know if you could comment on that. Thanks.
Yes, if there was a specific like point in the presentation, I can definitely clarify, but when we say USET states, we're just doing statewide. So for example, like when I mentioned like Massachusetts, we're doing the whole state of Massachusetts. For like specific wastewater metrics, if you're getting a specific report for your tribal nation, that would only go to you, and that would just include the counties that your tribal nation has land in. So for these general reports, the USET state would be just kind of the state as a whole. And then the USET PERCA would just, be the PERCA area. So I hope that kind of clarified a little bit better, but like on the vaccination, that's just kind of the state percentage as a whole.
Hearing no further questions, we can go ahead and move on, Dr. Mara.
Okay, thank you. Can you see my presentation or in the right mode?
You're in presenter view.
Okay, I always do that. I don't know. Murphy's Law. Okay, is that good?
Yes.
Okay, well, thank you for inviting me to present, and thank you, Anna. You gave a good segue, so I won't have to comment a lot on what you said, and you had better slides than I did, so good. So I'm going to cover two topics. One is influenza, and the other one is RSV. If we have time to do that, and I think we will. So I'll start with influenza, and the outline is, what is influenza? A little bit about epidemiology, symptoms, diagnosis, some statistics that I will go fast because Anna gave a lot of detail on that, and prevention and treatment. So the first thing that I want to mention is that viral respiratory illnesses, and in particular influenza, and we know that COVID does the same, have a greater burden on morbidity and mortality on Native Americans compared to other ethnic groups in the United States. So when you look at the seasonal influenza, Native Americans have higher mortality, 2.7 times higher than other ethnic groups. When you look at the H1N1 pandemic in 2009, the mortality was 4 times higher. And when you look at the COVID pandemic, the mortality is 2.4 times higher. Now, there's been on the right, you'll see a study that tried to look at risk factors for deaths in the H1N1 pandemic across 5 states, which included some Native American population. And these authors, what they found are that the age, pre-existing medical conditions, smoking, treatment with antivirals or not, especially not being treated, and barriers to healthcare access were risk factors for mortality. They claimed on their paper that AIA and race was not significantly associated. But when you look at the paper carefully, the number of Native Americans were less than 10% of the total population they evaluated. So it was really difficult to, and they claimed this on their discussion. They cannot rule. I mean, the state was not powered enough to really look at Native American as a risk factor, but it didn't pop up as one of the results. But all these things, we can modify many of these risk factors, not the age, of course, but smoking, vaccination, access to healthcare, that can be improved to decrease the mortality that we have. So what is influenza? It's a seasonal contagious acute respiratory illness caused by the influenza virus, and it affects nose, throats, and lungs. Now, I want to mention that one difference with COVID is that the influenza virus attaches to this receptor, sialic acid receptors in our nasopharynx. So these receptors are really abundant in the nasopharyngeal area. They're not very abundant in the alveoli or the pulmonary area. So COVID replicates better in the alveoli and less in the nasopharynx compared to influenza. And that is one of the reasons that it is speculated that COVID is a little bit more contagious, because when you cough and most of the viruses in the alveoli, you aerosolize the particles. And when you cough or sneeze with influenza, most of it is in your nose. So you create droplets, larger droplets that are not aerosolized for the most part. So this is the picture of the influenza virus, or a caricature of the influenza viruses. And it has two main receptors or proteins on the surface. One is the neuraminidase, and the other one is the hemagglutinin. And you'll see that the influenza viruses are called H1N1 or H2N3, and that is because of the type, the antigenic structure of the H, hemagglutinin, or of the N, the neuraminidase, and that's how they are classified. Now, the virus binds to that sialic receptor through the hemagglutinin protein, and that's how it's internalized into the cell. But when it wants to leave the cell, you need the neuraminidase to cut that bond between the virus and the sialic receptor, or else the virus will not spread to the next cell. And it's interesting to know, because not all of the antivirals that we have are a neuraminidase inhibitor. So they inhibit the virus from spreading from one cell to the other. But that's why it's important to treat patients really early in the disease, because if you wait 4 or 5 days to treat them, for the most part, the virus has probably spread through all your respiratory tract already. So as I mentioned, it replicates mainly in the nasopharynx. It produces large droplets, and the incubation period is shorter compared to COVID. It's 1 to 4 days. And people usually after day 5, in general, if they're immune competent, they're not infectious. But children and immune suppressed individuals may transmit the disease for longer periods of time, even a week or longer. So Anna already showed the graph on the left. I'm not going to go, and I think she had a more updated one. Mine was on February 3rd. But the interesting thing, look in the right-hand side, you can see the flu activity peaks by months in the United States since 1982 through 2021-2022 season. And the majority of the outbreaks have occurred, the peak of the outbreaks or the epidemics have occurred in February. Now, this one came a little bit earlier for us, and probably now it's damping down, and hopefully it won't go up again, but it can, because we've had mainly influenza A circulating. But remember, there's also influenza B, and sometimes you see like a bimodal curve. You have influenza A hitting first, and then influenza B comes later, or vice versa sometimes. But usually it's February, the highest cases of influenza in the United States. But you can see that you have peaks in January and December, and depending on the year that you're looking at. So the symptoms of influenza, the main ones are fever, chills, cough and chest discomfort, muscle, body aches, headaches, and fatigue. And usually with influenza, the patient can pinpoint exactly at what time they got infected. They were fine until 9:30 p.m. when they were watching their Netflix movie, and then suddenly it's lightning hit, and they had a horrible headache, and their body seems to be in extreme pain. And so you can time it. COVID, you can't time it that well. COVID, the patient starts getting sick slowly, gently in a few days, and then they peak with their illness. But it's important to differentiate influenza from the cold, especially when you're trying to convince patients to get vaccinated, because they said, oh, I have cold many times and nothing happens. Well, cold is not influenza. And usually the cold does not have the fever, does not have the body aches that influenza carries. And mainly the cold has rhinitis symptoms. So it's upper airway symptoms, not systemic symptoms. Now, in children, vomiting and diarrhea may be the presenting sign, and pediatricians are well aware of this. And so, any child with vomiting, diarrhea, and a fever in the winter months where influenza is active should be considered for the differential diagnosis of influenza. So the problem with influenza is that it can get complicated, sometimes by not life-threatening infections like ear, nose, and throat, sinus infections, or otitis media. Usually these are bacterial infections that complicate the course of influenza, but sometimes the complications are more severe. You can have myocarditis due to influenza. You can have pneumonia, which has a high mortality. Or if you have a COPD or asthma, it can exacerbate your underlying conditions. And rarely, but unfortunately, we do see these are encephalitis or spinal cord inflammation, aseptic meningitis, et cetera. And these are severe complications of influenza. And sometimes not recognize that they are tied to influenza, because influenza happened, a few weeks ago, and 2 or 3 weeks later, the patient presents with all these complications. And of course, people die from influenza. And in the United States, about 40,000 people die every year from influenza. So not everybody has the same risk of complications, and this is very similar to COVID in some aspects. But regarding age groups, if you're over 65, or especially if you're under 2 years old, you're at much higher risk of getting complications from influenza. That's why it's important to vaccinate children, which sometimes it's a problem and parents don't want to do that. Immune suppression is a risk factor. Pregnancy up to 2 weeks after partum increases your risk of mortality. Any children and adolescents taking aspirin, because they can cause a liver failure, the combination of influenza plus these medications. Native Americans, as I mentioned, are at higher risk just because of their ethnicity, and obesity, and patients who are on long-term care or nursing home residents are at higher risk. And on the right, I'm not going to go through each line, but anybody with chronic conditions, like the ones listed there, COPD, renal, liver problems, et cetera, are at higher risk of getting complicated. And why is this important to know? Because you want to offer vaccination to everybody, but especially to these high-risk populations, because they are at risk of having more problems and even dying from influenza. So let's go briefly to diagnosis. So there's 3 types of diagnostic tests. One is the antigen test, the ones that we've used for many years. Problem is their sensitivity is not that great. It's about 60 to 70% sensitive. And some, depending on the kit you're using, could be as low as 40 or 50% sensitive. So when you get to 50%, that's like flipping a coin. I mean, I can guess it's just as good as the test can predict if someone has influenza. But the antigen tests are useful if they're positive. If they're negative, during the flu season, if they're negative, they do not rule out influenza. Molecular tests are much better. They're the ones that are recommended by the Infectious Disease Society of America. And it's the ones that we all should be using. And culture is the gold standard, but it's for research or epidemiology. It's not used in clinical practice because it'll take several days, at least 3 to 4 days, until you get a result back. And that's not helpful clinically speaking. So this is a busy chart, but I just want you to focus on the little highlighted red rectangles that I've placed here. So we should be using molecular assays. We should not be using antigens because of the lack of sensitivity. The molecular test, there's many types. You have rapid molecular test, which is, for example, the Abbott ID Now. Also, you have the Cepheid, which is it's a PCR. And they have high sensitivity and specificity, but depending on the test, it may not tell you which influenza type it's the one that the patient has. And that may have some treatment implications. Then you have your conventional PCR, which takes longer time, 1 to 8 hours, depending on the machine that you have. It also has high sensitivity and specificity, but it will tell you what type of influenza, if it's A or B, that's the patient has. And then you have the multiplex PCR assays, which it's a panel of 15 or 20 different viruses. I mean, from 3 to about 20. So you have the simplest one that does RSV, influenza, and COVID. And then you have others that will detect metapneumovirus, enteroviruses, rhinoviruses, et cetera. And the problem is just the cost. When you get to the multiplex PCR assays, you're talking about $150 or $180 the cost of a test. When you're talking about the rapid molecular test, it could be down to between $30 and $50, depending on which company you're using. So the Infectious Disease Society of America came out with a decision tree that I'm not going to go into all the details, but I just want to point out something that's very important. If you're going to pay attention to what the test result is, do the test. If you're not going to pay attention to what it says, then just go clinically with your diagnosis. So when you are in the influenza season, like we are right now, that's why I was asking Anna about what's the threshold that you use. Like if you have 2.8% of ILIs, then you're still in the influenza season. Anybody who presents with influenza-like illness, you have a 70% chance that they have influenza, and you can go ahead and treat them with antivirals just with that clinical diagnosis. But the tests, in my opinion, are helpful as long as you use them. So it starts with, does the patient have signs or symptoms of influenza? If the answer is yes, next question, is the patient going to be admitted in the hospital? Yes or no? If the answer is yes, you test them for influenza, but you start treatment immediately. You don't wait for the test results. If the test comes back and if it's negative, and if you're going to say, okay, I'm going to pay attention to the result of the test, then order the test. And if you're going to treat that patient for influenza, no matter what, don't waste money on a test. Just go ahead and treat it. Now, if the answer is no, the patient's not going to be in the hospital, then the question is, will influenza testing results influence your clinical management? And if the answer is no, just diagnose it clinically, start the patient on treatment if they're at high risk of complications, and that's the way you should go. So in summary, like any test in medicine, use it if it's going to change your management or it's going to change your prognosis. If not, don't waste money on any test, and use your best clinical judgment. Regarding prevention, yearly vaccination is the most important way to prevent influenza. But then you have the whole list of things that everybody here is used to because we've had COVID for the last 3 years, and we've gone through all these measures, which are the same: wash your hands, clean and disinfect surfaces, avoid touching your eyes or mouth, etc. But very important thing: wear a mask, because you can see that we basically on the 2019-2020 season and even the 2020-21, we hardly had any influenza. And it could be many explanations, but one of them is because we were using masks. We were not trying to avoid large gatherings, and when we went to a place where there was a lot of people in a closed space, we would use a mask. So the mask really protects you a lot better from influenza than from COVID, because the masks are really good for droplet prevention transmission. They're for aerosols, they help, but they're not as good as preventing viruses transmitted by large droplets. So mask is an important tool, especially on your high-risk patients, to continue using. So the influenza vaccine, the types of viruses it has, it's recommended by WHO based on the previous year, and they're trying to predict what's the virus that's going to circulate. And sometimes there's a good match and sometimes there isn't. But it's always better. There's always a certain percentage of match, and it's always better to get vaccinated. It has the 2 most prevalent influenza A viruses and the 2 most prevalent influenza B viruses. So it's a quadrivalent vaccine. You can, and I'll go over on the next table on some of the types of vaccines, but some are intramuscular shots, some are normal dose, some are high dose, especially for older people. And there's also a nasal spray flu vaccine for individuals that are 2 to 49 years old. You can use that vaccine. So I'm not going to go over details of the whole chart, but I put this together so you can choose what influenza shot you want to give your patients. So these are all the types of shots we have. We have the standard flu shot that's grown in eggs. We have a cell-based flu shot for people who say that they are egg allergic. Well, you can use this shot. It's egg-free. Then you have recombinant flu shots, which are also egg-free, and they do not use the whole virus. It's a recombinant parts of the viruses, and it has 3 times the antigen concentration of the other compared to the other vaccines. Then you have high-dose flu shots based on eggs that has 4 times the concentration, and then you have adjuvant flu shots, and then you have attenuated, egg-based attenuated flu nasal spray vaccine. So you have options for all the people that, I'm allergic or I'm older, I want a higher concentration. Using the ones with higher concentrations are better in people who are older because it gives you a better immune response when you use more virus. You also get a little bit more side effects. And here you have the chart of which ages you can use each vaccine, and so you can advise your patients properly. So the benefits of vaccination is, and this is very clear to express to your patient. I mean, this is very important that you express this clearly to your patients. It may not prevent the influenza virus infection. So you can tell your patients, look, the vaccine you may still get the flu with the vaccine, but you're not going to get the flu because of the vaccine, because these are dead viruses or particles of viruses. Now, people will say, well, I got the flu vaccine last year and 1 week later I was sick. Well, that's because they actually got the flu besides the vaccine. It takes 21 days for the vaccine to protect you. So you can get the influenza virus within those 3 weeks. And it's not the vaccine can never give you the influenza infection. But despite being properly vaccinated, you can still get infected. But the beauty of it is that, very similar to COVID, you will decrease the risk of hospitalizations and the risk of dying from influenza if you are vaccinated compared to those who are not vaccinated. And also the other selling point is that, okay, maybe you're a young, healthy individual that don't have any risk factors, but you live with grandpa. So if you protect yourself, you're protecting grandpa from getting infected and dying from vaccine. Unless you hate grandpa, and that's a good excuse to infect him. But if you're a normal human being, you should try to protect the elders. So these are common questions that I already covered some. Why do I need to get vaccinated every year? Because the virus changes. Every year, there's a little bit of different structure of the virus. Does the influenza vaccine cause the flu? The answer is no. Can I still get the flu if I have been vaccinated? And the answer is yes, you can still get the flu, but you will not die from the flu. And if I have already had the flu shot, if I already had the flu, should I get vaccinated? So the answer is yes, because in one season, you may have 2 viruses circulating. And maybe now you come in with influenza A. But in a month from now, we're going to have influenza B circulating, and the vaccine will protect you against the 4 most common viruses. So the answer is yes. Not when you have 40 degrees of fever, but when you get over it, get the flu shot and be protected for a second flu that you may acquire during that season. So let's go to treatment. This is a cartoon of a respiratory cell, and here's the virus attaching. Remember, the hemagglutinin protein attaches to the sialic receptor in the cell, then the virus is internalized, and then the virus starts replicating, and then you have a new virus that is packaged, and then you have the virus leaving the cell when the neuraminidase can break that bond between the sialic acid receptor and the hemagglutinin. So most of the older antivirals that we have, antivirals, are neuraminidase inhibitors. And here we have oseltamivir, also known as Tamiflu, zanamivir, and peramivir. And then you have the new kids on the block, which is baloxavir, and these inhibit the transcription and replication of the virus. And these are the new drugs that we have available for influenza treatment. So here's a chart that summarizes the 4 drugs. How do you administer them? So baloxavir, oseltamivir are oral, peramivir is intravenous, a single dose, and zanamivir is inhaled. The problem is that on this season, we were not able to get either peramivir or zanamivir. It was kind of out of stock, but we were able to get the first 2 of them. Now, I want to explain why is baloxavir FDA approved, but not CDC recommended, and oseltamivir is not FDA approved but CDC recommended. Well, when oseltamivir, which is the oldest one that we're using, was approved by the FDA, it was not when the FDA approved it, it was not for complicated influenza. It was for uncomplicated influenza and low-risk patients. Then there were a lot of studies that proved that it's useful for that reason, for complicated patients or high-risk patients. That's why the CDC recommends it, but they never went through the FDA again to get the approval of the FDA for those indications. On the other hand, baloxavir got approval for patients at high risk for complications, but there's still not enough experience, and that's what the FDA prefers oseltamivir compared to baloxavir in patients that are high risk for complications. But if that's the only drug you have, I would use what you have. It's always better than no drug. So indications for treatment they're pretty simple. Anybody with high risk of complications. Remember, the high risk list, I already showed it to you. And it's basically anybody with comorbidities, Native Americans, extremes of age, pregnancy, etc. Or anybody, regardless of their risk, if they're already complicated, they are being hospitalized for influenza, you need to treat them. Or if the illness is progressing, and this is the example would be you have a patient that could be healthy and they got the flu, and on day 4 or 5, when they should be getting better, they're not getting better, they're getting worse. And then that's an indication to give them an antiviral. Now, you can consider treatment in a completely healthy individual without any risk factors, as long as you give it within 48 hours. The reason would be because their duration of illness will be shorter, and that can be an advantage to that individual patient. And also, it prevents transmission of this person will decrease the risk of transmitting the virus to other people. So that's an indication for patients without a risk, but you have to give it within 48 hours. Now, I want to take the myth away about the 48-hour rule, which most of our providers have in their brains, because that's what it was implanted in our brains many years ago. Like, you only give these antivirals if the patients have been symptomatic within 48 hours. Why? Because after that time, they don't work. That statement is partially true. The sooner you give the medication, the most likelihood it will work. But when patients have high risk of complications, or when patients are being admitted to the hospital, don't pay attention to the 48-hour rule. You still give them the antivirals. And many associations that I'll mention later recommend this. The CDC, the Pediatrics Association, the IDSA recommend that if you have high risk of complications or you're being hospitalized, you should get the antivirals no matter how long you've been symptomatic. Here, this is just a chart summarizing meta-analysis or studies that looked at the different 4 antivirals in patients, in low-risk patients with uncomplicated influenza. And basically what they show, all of them show the same thing, that it decreases your duration of symptoms. And it may vary, like for example, oseltamivir from 112 hours of symptoms to 83. So you're saving a day or a day and a half on each of these antivirals. But the advantage here on uncomplicated influenza and low-risk patients is that they will be sicker for a shorter period of time. And that's the summary of this slide. On this slide, on high-risk individuals, what we see is that all of these antivirals decrease the risk of complications. And here you'll have, with oseltamivir, 12% of the patients had complications compared to placebo, 18%. With zanamivir, 14% with placebo had complications. I'm sorry, 14% versus 46%. And with peramivir, 8% versus 13% with a placebo, and very similar to oseltamivir. So all of these antivirals, there's really no great benefit one over the other, decrease the risk of complications. Some studies say that baloxavir decreases the risk a little bit lower, but I think the data is not sufficient, in my opinion, to give it that advantage right now. Just keep in mind that all of them will reduce the risk of complications. The only important message on this slide is on the lower left-hand corner. This is baloxavir versus oseltamivir versus placebo for patients at high risk of influenza. And what it showed is that either of these 2 antivirals decreases the risk of complications. But when the patients had influenza B, the only one that really worked was baloxavir. Oseltamivir was really similar to placebo in regarding time to symptom alleviation. So that's why, as I was mentioning, if you're doing a diagnostic test and the patient has an influenza B, and you have the choice between oseltamivir or baloxavir, I would prefer using baloxavir on that patient, based on this data that we have right here. If you don't have that data, I would say just use oseltamivir because it's much cheaper. I'm not going to talk a lot about children, but it's important to vaccinate everybody, all children 6 months or greater. Remember that they have high morbidity and mortality, especially when they're less than 2 years old, but also when they're less than 5 years old. The first time you vaccinate a kid, they require 2 doses of influenza vaccine 4 weeks apart. And when they're younger than 6 months, they rely on maternal antibodies. And that's why it's very important to vaccinate the mom during pregnancy. Because she'll pass those antibodies to the baby and protect that baby for the first 6 months. And children, unfortunately, have complications. And here are some of the risk factors. And you can see American Indian and Alaska Native children. They actually, unfortunately, have the highest mortality due to influenza compared to any other children from other ethnic groups. So I really like this study, and look at the graph on the left. You can see that if you give the antiviral, and in this case, I think it was oseltamivir what they used. Yeah, oseltamivir. If you give it within 6 hours, you reduce the duration of illness by 3.5 days, which that is very significant. When you give it 12 hours after symptoms started, you reduce it by a little bit lower, 3 days, and so on and so forth. The longer you start treatment, the less impact the antiviral has. But if the patient has a high risk of complications, no matter if they had symptoms for 4 days, you still can offer them the antiviral. And here's the guideline recommendations for patients with delayed presentation. The CDC, the IDSA, the American Academy of Pediatrics all recommend that if a patient has high risk for complications or they're being hospitalized, you should offer them antiviral treatment, regardless of the duration of symptoms. Real briefly, there is a role for chemoprophylaxis, but it's very restricted to certain situations. Like if you're in a nursing home and suddenly you have 2 patients with influenza, that means you're probably going to have an outbreak, and you can give antivirals to all the other residents, regardless of vaccination status, to prevent them from getting infected. But this is not supposed to be used for anybody who comes to your office and says, okay, I want to protect my household. There are exceptions. If your households are at high risk, like you have a transplant recipient as part of your household, you may want to prophylax them against influenza. But this is not for general use. It's for very specific situations that I'm mentioning in this graph. And these are the 3 antivirals that have some role in prophylaxis. So the only one that's not here is the peramivir, which is intravenous, but the oral ones and the inhaled ones, they can be used for individual and 2 of them for community outbreak situations. One last, I think this is my last slide, yeah. So one thing I want to mention, so the key here is to give patients treatment quickly. And you know that our system does not favor that. Unless you have a walk-in clinic that someone with the flu can come in immediately and be seen by a provider, they're not going to get treated quickly. So you need to educate the population about the importance of early diagnosis. You have to have diagnosis in place. And one thing that could really ease all these issues is doing telehealth with your patients. So if you have a system that the patient can call you and have a telehealth visit within a few hours that they started feeling like they have the flu, you can decide if you want to treat them or if you want to test them and then treat them. And that would probably deliver better care. Okay, I'm going to jump into RSV now, which is, I think, a virus that we as adult physicians don't think about a lot. And I'm basically going to focus on adults because I'm not a pediatrician. But I'm going to try to answer the questions: what is RSV? How throughout your life regarding ages, what happens? What is the burden of RSV? A little bit about the epidemiology, symptoms, diagnosis, and the relation with COVID. So RSV is an RNA virus, and it replicates in the airways, very similar to what influenza does. And it can infect you in any age of your life. You can get infected, and it can in healthy adults. It usually causes upper airway disease, which is benign, But in older patients or in children, it causes small airway disease, which could be problematic and even lethal. So regarding transmissibility, this chart compares measles, for example, which is the most transmissible of all these infections, meaning that one patient with measles will infect 16 or 18 other patients if they're not immunized. And then comes pertussis, mumps, and RSV is in the fourth place. So RSV is a little bit more contagious than influenza, and a little bit less contagious than COVID. So it's a seasonal disease. You'll see it in the winter periods in North America and in the winter periods of Europe, but you can see it between October and February usually. So if you have 1 million people with symptomatic RSV, 420,000 will need medical attention, 177,000 will be hospitalized, and 14,000 will die. So it is a pretty severe disease. Average number of deaths from influenza per year are 40,000. And here you have about 14,000, and this is in individuals who are 65 years or older. So this usually it's not serious if you're a young adult with not an immune compromised, but if you're older or immune compromised, it can be a very serious infection. So in the early stages of life, the disease affects the lower airways, like it can be bronchitis or bronchiolitic or bronchiolitis with wheezing. But when you get older, and if you're immune competent, usually it's a cold type of symptom that you will experience, so not a severe infection. But once you go over 65 or 70 years, like in this graph, then your immune system starts declining, and you can have lower respiratory diseases or exacerbations of asthma or COPD. So this disease can become a little bit more severe when you're on the extremes of age or when you're immune compromised for any reason. This is a busy graph chart, but basically it's telling you you cannot differentiate RSV by symptoms from other infections, in this case, influenza. So you can look at the percentages, and they're very similar for all the symptoms: nasal congestion, cough, sputum production, shortness of breath, wheezing, etc. So there's no way you can tell a patient has RSV or they have the flu. The problem with diagnostics is that many adult providers do not test for it. And why? Because they say, well, I don't have treatment. Why am I going to test for it? But there's many reasons that you should test for it. First, it can spread through a facility. So if a patient's in a nursing home or you're being hospitalized for a respiratory infection, it's very important to isolate those patients if they have RSV. And also, if an older patient with comorbidities gets RSV, their outcomes are poor. So it's very important, despite the fact that you don't have specific treatment yet, or we don't have a vaccine yet, that at least you can counsel your patient that this infection could be complicated and you need to observe him more frequently than you would a patient without risk factors. So this is a study that was published in the New England Journal of Medicine several years ago. I think it was 2015. And it looked at all the types of infections that cause pneumonias in patients, in adult patients. And you can see here that RSV is number 5 in frequency compared to rhinovirus, influenza, pneumococci, or human metapneumovirus. And a good percentage of these RSV infections are co-infections. The patient has RSV and something else. And when you look at the frequency of pneumonia per 10,000 persons per year, it increases with age. So if you're 80 years old, the number of pneumonias that you will have per 100,000, per 10,000 patients, is much higher than if you're 50 to 64 years old. The other driver for pneumonias are comorbidities. So this study looked at different comorbidities and the odds ratios of hospitalization if you have RSV. And you can see that except for a solid organ transplant, which probably was a low number of patients, people with strokes or CHF or CKD, et cetera, have higher risk of being hospitalized if they get RSV compared to patients who do not get RSV. And also, if you're older and have all these comorbidities, your risk factor for poor outcomes is much higher than if you don't have these comorbidities. So in another way, if you're a 45-year-old adult person without comorbidities, you probably will just have a cold from RSV. But if you are older than 65 or you have comorbidities, you're at higher risk for hospitalization, and you also have a higher risk of dying from RSV. And remember, we don't have treatment for this. And the only prevention that we have is using a mask and avoiding crowded spaces when you are at high risk of having a complication. And that's what I would advise our patients. So this is a graph looking at mortality from RSV hospitalizations, and it's stratified by age. So the mortality was much higher if you were 75 years or older. This is a survival curve. So at 12 months, for only 40% of the people who were 75 years and older were alive after having an RSV infection, compared to around 78% if you were 60 to 74 years old. And this is the risk of mortality days after admission in people who have CHF. So no CHF, no congestive heart failure. They have heart failure, but there was no exacerbation of their heart failure when they got admitted, or their heart failure was exacerbated, and all of these had RSV. And the mortality is much higher, the survival rate is much lower in those who have heart failure and came in with symptoms of heart failure and RSV when they got in the hospital. So that's an interesting prognosis factor. And we don't pay too much attention in RSV in adults, but survival after an influenza or an RSV admission is much lower in patients who have RSV compared to patients who are admitted for influenza. And these are other parameters that they saw RSV was associated with prolonged hospitalizations, admission to the ICU, exacerbation of their COPD, pneumonia, and mortality. Interestingly, during COVID, same happened with influenza. We hardly had any RSV, but now it came back. And we had a little outbreak of RSV here where I work, and I think it was in late December, early January, or November, December, and basically in children. And we had some cases of adults being hospitalized. Now, what happened here is probably that we were using masks, and that schools were shut, and people were not getting exposed to other people as much, and so transmission had decreased. So I'm not saying we have to shut schools or anything like that, but wearing a mask is so simple for most patients. So if you have a patient that has high risk of dying from RSV, you can tell them, if you go to the mall, wear a mask. If you're going to be with in a place that doesn't have good ventilation and there's a lot of people there, wear a mask, because right now there's no way I can prevent RSV from infecting you, because we don't have a vaccine and we don't have treatment to give you if you get infected. So the good news is there are some vaccines in the works. They're not approved yet, but I expect that in the next year or two, we will have a vaccine for RSV. And it's very important that you understand, that we all understand how severe this disease can be. So when the vaccines come out, that's another vaccine that you will have to convince your patients of getting. And of course, we will review the data that the vaccines have, before we make our decisions, make sure that they're safe and make sure that they're effective, especially in preventing bad outcomes. And if that's the case, then we certainly will need to recommend it to our elders. So in summary, RSV is seasonal, happens in the winter months. Usually we don't do tests to diagnose it, but we should, at least in patients at high risk of complications. Impossible to identify just with symptoms, you need a test. There are risk factors for poor outcomes, which basically includes age and then the presence of other comorbidities. And RSV is not going anywhere. It came back after we stopped using masks, and hopefully we'll have a vaccine and maybe a treatment in the near future, but I think vaccines are closer than treatment than treatment is. Okay, and I'll stop there, and if there's any questions, be happy to answer them.
Okay, great. Thank you, Dr. Mara, for a great presentation. I believe we have a question from Nancy Pierce somewhere. Oh, yes. And I wanted to wait to ask you this, Dr. Mara. What are the plans for most clinics after the May cutoff? Are they stopping testing for COVID? And how about vaccines? If you know.
Testing, and what else?
Vaccines.
So, okay, enlighten me a little bit about this May cutoff. Maybe it's something I'm not aware.
It's the pandemic. They're ending the emergency declaration on May 11th.
Oh, okay, I just learned about that. Interesting. We're still having like 500 people die every day. So I'm not sure if that's a real measure or a political measure. Okay, so what would I do? So it depends on the data that we have. I mean, we're still having infections and we're still having people dying every day at the rates that they're dying today from COVID. You know, vaccination. All I can tell you for sure is that you should be fully vaccinated by the regimen, the schedules that we have right now. I mean, you have 2 doses of an RNA vaccine and you have a booster dose. 2 booster doses. I mean, that would be the ideal situation. Now, if we will need a booster every year or not, it seems like we will from the data that's coming up, but I don't think that's a decision that has been made yet. And that has to be based on science and see if that really helps you improve your immunity to the circulating virus. My guess is that probably we will need it, but I don't think there's enough data to tell you that now. Regarding testing, you know, I'm a firm believer that we certainly need to keep doing surveillance. That's for sure. Epidemiologic surveillance on the circulating viruses. Now, if I'm seeing a patient that's symptomatic, there's no way I can say this is COVID, influenza, RSV, or anything else if I don't test them. And there are specific treatments for COVID. There are specific treatments for influenza. So I think we need to test symptomatic patients if we have the test available. To try to treat them, you know, and offer them treatment if they have a virus that's treatable. I don't think we need to continue screening asymptomatic individuals. Some facilities are still doing, but when you're working in a facility, I think that you should be wearing masks when you see patients. Today, you know, in May, I don't know what's going to happen in May, but from the data that I've seen so far, I think we still have activity of COVID, and you can transmit it even asymptomatically. I don't know if that answers your question, but that's the best answer I can give you.
I did put a link in the chat if you wanted to see exactly what's going to be impacted. All the vaccines, testing, treatment will still be available, but some like insurance coverages will potentially, depending, you know, what you might have, will impact cost of things. So I would just kind of read through that and see what's maybe applicable to your specific circumstances, but everything will still be authorized.
Thank you.
Any other questions for either Anna or Dr. Mara? Okay, hearing none, we can go ahead and adjourn for today. Next month, we have the topics of HIV and hold on, sorry, HIV and AIDS presentation. Dr. Mara has given that, and Whitney Essex as well. So look forward to that. And we will see y'all second Friday of the month. Thank you.
Click the link in the chat for CEU.
Thank you.
Thank you.
Thanks, Erica. Thanks, Faith. Bye.